Today, we are pleased to welcome Wayne Kepner, a postdoctoral researcher at Stanford University School of Medicine. Dr. Kepner earned his Master's of Public Health at San Diego State University, where he worked with Dr. Lang and Dr. Zuniga, and completed his PhD through the joint SDSU UC San Diego program. Yeah, give it up for Wayne. While at SDSU, he was the co-creator for Aspects for Recovery and helped organize the first very Recovery Science Colloquium. Contributing to the early development of recovery-focused scholarship and community on campus, his current work sits at the intersection of addiction science, implementation science, and health systems with a focus on improving access to medications for opioid use disorder and strengthening the interface between clinical care and community recovery supports. Today, he will present his K01 proposal, which examines how implementation strategies can bridge persistent divides in addiction treatment and generate more scalable, equitable models of care. Welcome, Dr. Kepner.
All right, thank you very much. All right, let me see if I could get this all situated here. Mike. Is this working? All right. Here we go. Let me see. All right, everyone. Thank you so much for that great introduction. I'm so glad to be here. Is this also on Zoom too? Is like the camera here? So hi, everybody who's watching at home. I think my wife is watching with our dog Kenny, probably. Hi, Nora. I hope you are. Click here. All right. All right. So yeah, hi Nora, hi Kenny. Sorry I couldn't be here today. I am so happy to be back at San Diego State University. I'm going to go over a little bit about Aaron Brown. Good to see you. A little bit about SDSU's history. But before I get started, can I get a little bit of show of hands? Who's a student here? Who's a current student? Any current students? Over there in the back, SDSU student. That's how I started. Dr. Lang was literally the first person I met at SDSU. I remember I got in, my wife and I both got into San Diego State, Master's in Public Health. And I emailed him during the summer and I said, hey, I'm a student in recovery. I just got into this master's program. I don't know what I'm doing. Can I get an internship? And he's like, come on down to my office and let's talk. And he was literally the first person I met. He was also on my master's thesis committee. And Dr. Zuniga was also a part of my master's and my dissertation committee. So they've been with me from the very start. So it's really nice and touching to be back here. So thank you for having me. Give a round of applause to them. I feel like now I can, now that I've been gone for a few years, now I'm here at Stanford, or I'm doing my postdoc at Stanford here. So I started my journey at UCLA. I got my BA in history, and then I came here to San Diego State. Go Bruins. And go Aztecs. And now I'm at Stanford doing my postdoc in the Department of Psychiatry. Coming back to SDSU a few years later has really allowed me to see how great this place was. And I don't want to say I took it for granted because that's not what happened, but I wasn't really able to see how special SDSU was until I left. And what do I mean by that? Like when I walk in here, people at home can't see. We have a booth with Recovery at State. We have the Phoenix. We have Smart Recovery here. We have community members. When you see the video that they showed of naloxone, overdose awareness, and gambling, having all of those programs seamlessly, and Jen Reichardt's here too, doing counseling services, eCheckup to go, having all of those services seamlessly integrated in a natural way, I actually haven't seen that anywhere else. And I really want to give a shout out to everyone here who's doing such a great job. Other campuses do not have this. And it seems so natural here. And that's hard, right? So things that seem easy, but are not, that's really special. So coming back to SDSU, being at Stanford and other places who don't have these services, I can really see how truly special SDSU was and how lucky I was to have this education firsthand. So thank you everyone for doing the work that you're doing. All right, we'll get into my presentation. I just want to say this is the first recovery colloquium. It started in 2019. Dr. Horvath, who's a part of Smart Recovery, was our first speaker. We wrote a small grant through the what is it called? Instructional uh, related activity fund. We didn't think we were going to get it. And Dr. Zuniga emailed and said, we got it. Now we need to find 2 speakers in 2 months and set up a conference we had never done before. So Aaron Brown in the back there and others really, we put this together kind of not knowing what was going to happen. And here we are, how many years later? 7 years later, continuing to do this. So that's quite a feat. And I'm proud of it really was a partnership between students in the back, and also community members and administrators really going to bat for this topic and for the community. So thank you for that. Oh my God. All right, so the slides are a little bit wonky. So usually what I do is I'll show a slide here without that top line, self-help groups. Addiction treatment. We usually think of rehab, right? When celebrities go to rehab, that's what we think of treatment. When Lindsay Lohan or whoever gets into trouble, they go to rehab, right? We think that's what treatment is. And it is. A lot of people go into treatment. And if you see here, this is a list, I think this is of 2021, sources of recovery or sources of addiction treatment support in the United States. And if you see the top line there, self-help groups is by and large the largest source of addiction support in the United States. Now, Smart Recovery here to the right, that is one example of self-help group, Alcoholics Anonymous, other peer support groups as well. Most people who have a substance use problem or are curious about different lifestyles don't go to formal treatment. And we have that here at SDSU, right? There are a lot of students who are like, well, I don't know. I'm definitely not going to rehab. I have school. Like I have a final tomorrow. I'm not going to rehab, right? So they go to what we call, recovery support services, ancillary services, other types of support that are not formal treatment, right? But in our mind's eye, we think of addiction treatment as Lindsay Lohan rehab, right? That is not how it really works. It really is a whole system with self-help being the most accessed form. So given that, we are a room here full of professionals, right? I want to get a poll here. How many of you, with your maybe decades of experience, or if you're a student, a few months of experience, how many of you have gotten 1 full hour of education on self-help groups for addiction? If you work in the addiction field, can anybody? Yeah, Smart Recovery has. Yeah, Miriam has. When I give this presentation in a room full of psychiatrists, medical doctors, directors of medical facilities, they never raise their hand. And it's the most widely form of addiction treatment service in the United States, has been for a long time. I'm not criticizing the medical education system. There's a lot of things to learn, but I think we can do 1 hour of education on self-help groups, but we don't. So I'm going to start with a brief history of mutual help groups. So you can raise your hand. It's not going to be a full hour. I'm so glad Smart Recovery is here. It's not going to be a full hour, but when you leave here, I want you to have at least a brief understanding. What is mutual help? What is peer support? What is AA? What is AA not? So I'm going to ask a question. In the United States, right? We're just going to, or let's say in North America, what is the first example of a widespread mutual help group, movement, or organization for addiction? You don't even have to name it, but what group started it in North America? In all of North American history, what group do you think started it? You think AA? Okay, we got in the 1930s here. Anybody else? It doesn't have to be a specific organization. What peoples? Christians? Okay, that's good. I did my, as a general rule of thumb, whenever somebody asks, in North America, who were the first peoples to do something? The answer is almost always the indigenous, right? So we can start there. You can always, even if you don't know the answer, when somebody says, who are the first peoples in North America to do anything, say the indigenous. That's the right answer. All right, so I'm going to start off with Handsome Lake and the colonial crisis, right? So we traditionally think of mutual help groups as AA, started in 1935 by basically Christian-esque, upper middle class white men in the 1930s. Not really true. So in the 1790s, if you didn't know, the indigenous population in the United States and the colonials, our forefathers, had a complicated relationship, right? There were skirmishes, there were also alliances, but there was a lot of conflict and war between the two groups. In that early period, alcohol was used by colonial traders, by American traders as a form of technological warfare, as a form of trade. They used alcohol during peace treaties and other agreements to get better deals. And in that era of really turmoil and intergenerational trauma and frankly genocide, there was a huge alcohol problem among the indigenous population. Does that make sense, right? There's a lot of war, there's a lot of conflict. Whenever there's war, whenever there's conflict, alcohol-related problems are big. If you think about Ukraine right now, there's a huge opioid and alcohol problem among the Ukrainian population because of the war. So in this period, in the indigenous period, there was a similar alcohol problem due to conflict between the colonials and the indigenous. Enter Handsome Lake. Handsome Lake was a leader of the Seneca people, which is part of the Iroquois Confederacy in the eastern part of the United States. So he was like a upper leader kind of guy. And he fell into alcohol problems in a really bad way. And his family had basically come to the realization that he was going to die of alcoholism, and they were planning for his funeral. And towards the end of his life, as he's drinking himself to death, quote unquote, he had a vision. And in this vision, he heard a voice, and the voice said, if you and your people that you represent don't stop drinking alcohol, you will cease to exist as a people. And those are his words paraphrased. And from that moment in 1799, he recovered from alcoholism, and he developed this code called the Good Message. And he traveled around to all the different native confederacies and populations, and he delivered his message, which was alcohol is destroying our culture, and we need to stop. That's the first real large mutual help proto-organization where somebody had a problem with alcohol, decided to stop, and spread that message around to other people. And very importantly, at this time, alcohol and alcoholism, or alcohol use disorder as we call it now, was framed as a response to colonialism. Right? It was a symbol of colonial, I would say, infestation of the culture, right? So this is really important. This thread continues today. If you go to Wellbriety, have you all heard of Wellbriety or White Bison? There's the indigenous, it's basically the indigenous 12 steps. They don't use the 12 steps. This thread continues to this day in the Wellbriety indigenous movement. So circling back, mutual help groups started really from the North American perspective in the colonial period with the indigenous population. Now, again, so the theme that I'm going to keep repeating is mutual help groups, peer support is generally a response to the crisis of the era. So in the 1840s, urbanization, we've all heard of this, right? Rapid industrialization, the United States is industrializing, waves of immigrants, Germans, Irish, they came to the United States looking for a better life, right? And in this time, there were factories being created, manufacturing was booming. If you think about China today, we think of China as a manufacturing powerhouse, right? So starting in the 1970s, they came out of communism, they started making stuff, and now everything that we make is like made in China because like they have these factory bases, right? At that period in the 1840s, the United States was going through that same process. We slowly became the manufacturing powerhouse of the entire world. So if you can imagine Chinese factories now, like we know like sweatshops, right? We know that kind of that language. The United States had that same problem in the 1840s. So again, if there's a crisis, what happens? Men resorted to what we call the saloon, right? Saloon is not a bar. Saloon is much more than a bar. So the men resorted to the saloon where they drank heavily. And in response to that became the Washingtonians, which is the first real American mutual help group. The Washingtonians were the first teetotalers. Have you all heard of the term teetotalers? Yeah. Does anyone know why it's called teetotaling? Teetotalers? Teetotal. All right, so has everyone heard of temperance? Remember the temperance movement? The temperance movement was largely a Christian, a lot of women-led feminist movement about really, it was about drinking beer and wine and not drinking hard alcohol. So again, at this time, in the 1840s, people are coming in, they're working really hard. Hard alcohol, vodka, those kind of spirits were first coming into popularity. So the temperance movement was like, I'm not going to drink hard alcohol. I'm going to drink beer and wine. So that's temperance, right? So you go to a party and they say, here's a shot of vodka. Do you want to drink vodka? And they go, no, I don't drink vodka. He goes, oh, have you taken a temperance pledge? Or are you totally abstinent? And if somebody was totally abstinent, they'd be like total with a capital T, teetotaler. So they were the first teetotalers, totally abstinent from alcohol, right? And this was a big, fast growing organization. The things that carried out today was how would you call it? The telling of one story. So the main thing that they would do, the Washingtonians would come from the saloon and say, I have a problem with alcohol. They would sip them up in a stage like this with all their friends and family, and they would confess their story, right? And we still have that today in AA and maybe even Smart Recovery and other organizations. They would say, I have this problem with alcohol. I'm going to take this pledge. I'm going to be a teetotaler, totally abstinent. And this telling people your story, telling people on a group level what happened to you, and then now you're going to take this abstinence pledge. They were the first ones to do that, and that continues to this day. The Washingtonians flamed out pretty quickly. They didn't last that long, but they were the first kind of American mutual help group. And now this brings us to Alcoholics Anonymous, which a lot of people think is really the founding, but it's not. So Alcoholics Anonymous, again, was a response to the crisis. What was the crisis in the 1930s? Depression and prohibition, right? So we had this new kind of manufacturing culture, immigrants, we had, beer and wine, and now we have this like vodka, right? It's coming in, and it's kind of like, oh, let's make this law so that no one can drink. That's going to fix everything. Doesn't really fix everything, right? So Alcoholics Anonymous came out of this crisis. Dr. Bob and Bill W. came up with the 12 steps of Alcoholics Anonymous, and it really fused these multiple waves of recovery movements, right? So if any of you knows anything about Alcoholics Anonymous, you go and you tell your story, you take basically a pledge of abstinence, and you go around and you spread the good message to others, hoping that other people can also recover. So Alcoholics Anonymous, in many ways, was a combination of a lineage of mutual help for hundreds of years. And it continues to this day. I think they're having their 90th, or they just had their 90th or something like that. So again, summarizing, we're about to end this mutual help group thing. Peer support and mutual help in the United States has a long history. It's not just 1935 Alcoholics Anonymous. It started way before that with the teetotalers, the temperance movement, and the indigenous populations. And always, traditionally, has been a crisis response to what's happening in the current history. And today we have Smart Recovery, we have Mara, and we have psychedelics. We have all sorts of different mutual help organizations that I'll get into later. All right, before I get going, do we have any questions? I know I threw a lot at you, so I'm going to stop for questions. Any questions? Any comments? Thank you. All right, so I should be timing myself. So to give you a little overview, we talked about what a mutual help group is, and then I'm going to talk a little bit about how they work, the mechanisms of why they work, and then we'll move on from there. So how do they work? There's been a lot of controversy on this topic. If you're familiar with this topic at all, it's kind of a persistent debate among academics. Is like, well, AA has definitely been around and a lot of people use it, but how does it work? What are the mechanisms for change, right? Does it work? So in 2020, Cochrane review came out and definitively proved, at least from the evidence that we have available, that AA and 12-step facilitation, so sending people to AA, is just as effective as professionally managed services for reducing problems with alcohol. I'm gonna say that again. AA and 12-step facilitation is just as effective at reducing alcohol problems as professionally managed services, right? So now if you tell that to people who are professionals, some people don't necessarily like that, but the evidence says that's what's happening. If you're talking about abstinence, right, not just reducing alcohol harms, AA is at least as well and even better at improving rates of abstinence. Most importantly, substantial cost savings. AA is free. Smart Recovery, I think, is mostly free. Maybe you have to buy a workbook, but you don't pay for it. They're everywhere. So if you ever try to get an appointment with a doctor and you know the difficulties, if someone's having trouble getting into treatment, AA, Smart Recovery, and other 12-step fellowships and other mutual health support groups are available 24/7. There's definitely one going on right now. 5 key mechanisms of change: social support and network change. And the students here know this very well. So social support is people coming and really, I think about it like a study group. Has anybody ever been part of a study group? Do you necessarily gain a lot of skills other than just like coming together and holding each other accountable? Sometimes not, right? But that's what it is. So there's a lot of social support. There's network change. Like if you're studying with the kids who are getting A's, probably more likely to get A's, right? It's just like through osmosis, right? You learn all sorts of skills. Like, oh, this is how you take notes. Okay. Or so there's a lot of network change there, right? Cognitive restructuring. This is a little bit different. Shifting your identity to like being a person in recovery, or I am somebody who does this or does not do this. There's a little bit of identity restructuring, not necessarily. Behavioral changes, that's easy. It's like drink refusals, like, oh, I'm not going to go to that party. Increased self-efficacy. This one's really big, especially for young people. Being like, I can say no to alcohol and like not feel left out. Like I have those skills, like building that. We call it self-confidence in other ways, but self-efficacy, ability to move past those barriers. And then the last one, especially for middle-aged and older folks, spiritual and existential growth, talking about like what is the meaning of my life. It gives that kind of scaffolding of like having a higher purpose, spreading that good message to other people, gives a lot of people a sense of deep purpose, which in the modern day, I think can really be missing, All right, so yeah, any questions about that? The mechanism sometimes can be kind of confusing. I wish I could take Zoom questions. All right. So the first half of so we're about halfway done. The first half of my presentation was about mutual help groups. Now the second half of my presentation is going to be about opioid treatment specifically. Why is that important? Well, we're going through an opioid crisis, right? People are overdosing and dying. Like we saw the fentanyl test strips, right? Especially for students, they may not even know there's a fentanyl pill. They're, maybe trying to take a benzo that they have a prescription for and they ran out and they have a test coming up and we've actually had this, sadly happen, laced pill, right? So opioid use we know is an important problem. I'm going to go through very briefly the history of opioid treatment. All right, another history question, not just the United States, in the world history, what people were the first to do large-scale opioid maintenance treatment? The Chinese. So that's another hack. If anyone asks, in the history of the world, who were the first to do anything? It's most likely the Chinese. All right, so the Opium Wars in 1839, 1860, we're not gonna get into it, but the British were buying tea from China and, they were losing a lot of money, honestly. It seems kind of crazy, but they're buying a lot of tea from silver and they needed another trading tool. I mean, right now there's so many parallels with tariffs and China, but they needed another trading tool. So they started selling opium to the Chinese and really the rest of the world. A little known fact, we talk about the spice trade. Did you all know opium was considered a spice? When I was young, I was like, man, the British are making so much money off of pepper and spice. Didn't really understand it. When I was like, oh, they were selling heroin, I was like, that makes more sense. So in the 1830s, Britain was selling a lot of opium to the entire world. And there was an admiral, his name is Lin. He was a administrator. He was sent down to Guangzhou and said, take care of this huge problem. At that point, some records say 1 in 4 young men were addicted to opium. Imagine if in the United States, 1 in 4 young men were addicted to fentanyl. What would we do? That's what they were facing back then. So Admiral Lin, he had the power of the emperor basically, and he said, we're going to set up a large scale opioid replacement therapy. We're going to give opioid quote unquote addicts opium. And they set up huge state mandated treatment, which seems kind of like our methadone treatments today, right? So if you have a problem with with opium, we're going to give you opium. We're going to slowly wean you off. And they were doing this for millions of people in the 1830s, right? Fast forward to U.S. and the Philippines, early 1900s, when the U.S. colonized the Philippines. Did we all know that U.S. colonized the Philippines? Yeah, they don't really talk about that, but we did. And we inherited the Philippines after a war with Spain, and there was a bunch of people addicted to opium in the Philippines. So the US came in and said, well, we have to do something. We're going to replicate the Chinese system. We're going to give opium, or probably morphine at that time, to the Filipinos, and we're going to extract some money, and we're going to keep them stable. So this was kind of a playbook that has been written for a long time. So opium wars in China, US and the Philippines that we did. And this is kind of the British system. Usually history books start here, the medicalization of opioid treatment. Back then it was kind of like state controlled, right? So the US or the Philippines, they're doing like a state sponsored. Then we start to think about, well, maybe we can prescribe this. Right. So doctors, physicians, like your family doctor was like, well, you have a problem with opium. Let me prescribe you this new wonder drug called heroin, right? This is non-addictive, or this is going to help you with opium. So that's the start of the medicalization, the British system, which kind of continues to this day. That was like the start of the modern opioid replacement therapy. And a lot of people probably start here, the methadone revolution. Methadone has a long mechanism of action. So it stays in the system longer, right? So that's kind of the maintenance philosophy, like heroin and morphine and opium. They have a shorter acting life. This one lasts 24, 48 hours. So this is kind of, it was really a revolution. The system that came out on top of it, not so much, but the molecule itself. The modern era, we have buprenorphine, Suboxone. Again, medicalization of treatment. So now the doctor used to prescribe it in the clinic. Now the doctor can prescribe it outside the clinic, right? So you don't have to be within a hospital system. They can write a prescription and send it to you really over telehealth. So that's where we are today. And the advancement for buprenorphine, it has a ceiling effect. If you see the picture on the right, basically the premise is like you can take buprenorphine and over a certain amount, it really doesn't get you higher, is the way they say it. Whereas methadone, you really can just keep taking more, and people do overdose and die on methadone. So Suboxone doesn't have that same dangerous profile. So this is the first like population level medication where doctors are able to prescribe it basically over the phone, if you think about it. So we've come a long way. Why is all of this important? All right. So that's the history lesson. And then we get into the actual my research. Any questions or comments? So we had, mutual help group history, and then we had opioid replacement, opioid maintenance history. Any questions? Good. All right. Yes. That's a really prescient question. That I'm going to get into that, and I'm gonna try and answer that question with the data that we have available. To answer your question honestly, I don't know. I have suspicions and I have historical data to suggest what may happen, but I don't know. And this is kind of the question of our era and my career and our day is like, we have this opioid crisis. We have these tools available. What are we going to do? How are we going to apply it? And I don't know, but I'm going to try and answer that question. Good question. Anybody else? All right, we're almost done. Integrating medications for opioid disorder and mutual help groups. Seems kind of obvious, but it's not. Two effective yet conflicting pathways. MOUD, that's opioid maintenance therapy, medications for opioid use disorder, so Suboxone, methadone, those kind of things. MOUD are the most effective pharmacological treatment, so medication treatment. It decreases drug use, emergency room visits, and overdoses. So this is what I was talking about. We have this maintenance treatment history, right? So when you have an opioid crisis, you can give out medications, other opioids to help cravings and all sorts of other things. Mutual help groups provide complementary benefits through peer support. So again, we have mutual help groups like Smart Recovery and AA and others that provide peer support and other types of, we would call it like social support or behavioral support. We have two really effective pathways, we'll call it, that have been around for hundreds of years. But oftentimes in the medical field, they are at odds, which sounds really crazy, but it's true. We have a fragmented system. If you do go to rehab, right, the rehab that we see on Celebrity Gossip, the rehab that we see, facilities that don't offer medication replacements are 8 times more likely to offer recovery support services such as mutual help group. So if you go to rehab and they're like, we don't want to give you medications for your opioid use disorder, 8 times more likely to have an AA meeting there. Conversely, if you are giving medications, you're 7 times less likely to have support services there like AA or mutual help group. So in the rehab system today, it really is, we call it like a bifurcated system. You have one treatment modality or the other. That's the reality today. Why does it matter? Why does integration matter? In optimal settings, combining medication with mutual help produces a 25% higher likelihood of treatment completion compared to medication alone. So what does that mean? If I give you a medication and I send you into treatment and it's 6 months, right? You have some kind of outcome shown here on the bottom. And then if you include a mutual support like a AA, Smart Recovery, Narcotics Anonymous, it improves your ability to complete treatment from 43% to 67%, about 25% increase. This is one study, right? That's a lot. 25% increase in our field is a huge number. If you think about how many people are going to treatment, we have 20,000 treatment facilities. We have millions of people who go to treatment and need treatment. 25% increase is a lot. Actually, I'll go back there. 25% increase is a lot. So then what is the reason that people don't offer both? Well, there's philosophical reasons, there's ideological reasons, but really it comes down to the idea that medications are not welcome in mutual support groups. So I would take Smart Recovery out of that. They're really, I would say, Smart Recovery does a really good job. Very good. But I'm going to focus on the hard problem, which is 12-step programs, which are Alcoholics Anonymous and Narcotics Anonymous. The idea that medications are not welcome in 12-step groups is partially true. We have to recognize that. The reality that when people go to a 12-step meeting, and they will be faced with negative comments, people will tell them that they're not clean. People will tell them to get off your medications. And subsequently, people die. That is a reality. It does happen, and we need to address that. In many ways, this is the core problem of why I believe this bifurcated system exists. Two systems, both effective, can't get along. Okay, Started with the premise, stigma exists. Stigma exists, yes. How much does it exist? In research and in our field, that's always a question, right? First question, does something exist? That's an easy question. Yes, it exists. Then the second question is, how much of it is there? We often don't ask that second question. We say, yes, it's there. How much of it is there? I don't know. Number two, we don't have, I'm going to be honest with you, we don't have a lot of data on this. I'm not going to answer that question for you today because I can't. We don't really have studies, which that's a different question or different problem. But there is one really good study who looked at this problem. It was 300 mostly African American patients in Baltimore going to methadone treatment, longitudinal study. So they followed them for, I think, over a year, maybe 18 months, right? And they wanted to ask this question. If you have methadone maintenance therapy, if you're going to a methadone clinic and you also go to Narcotics Anonymous, what's your treatment completion rate? And what's your chance of finding or receiving a stigmatizing message? Do I have it on this side? Sorry, I had it in the speaker notes. So I said it to you before, this is the finding. For patients in this study who are on methadone maintenance, who also chose to go to Narcotics Anonymous, 25% increase the treatment rate. Okay, here it is on the right. 33% of patients disclosed that they were on medication. So look at the top right screen, philosophical conflict and stigma. 300 people went to Narcotics Anonymous on methadone maintenance, right? 33% disclosed their status. So let's say there are 300 people, 100 people said, I'm on methadone maintenance. Of those, 33% felt or got some kind of negative stigma. So of those 100, about 30 got some negative stigma. And of those, I think I have it in speaker notes that are not here, maybe 9% eventually reduced their medication access. So they tapered early or they got off their medication. Apologize for not having the direct numbers. But I do remember over the 300, 9% discontinued their medication. Okay. 9% discontinuing their methadone. That's not good. But also compared to what? That's the question, right? So yes, stigma exists. 33% people will disclose. Of those, 33% will discontinue or no, receive some kind of stigmatizing message, and total 9% discontinue. That's terrible. But when you compare it actually to general society and healthcare society, it's actually pretty standard. One of my first papers that I wrote was on looking at Reddit, the treatment facility, or Reddit, the social media site, and I looked at sources of stigma that people were experiencing for opioid maintenance therapy. Healthcare professionals are actually number one. AA, definitely up there. I think it was maybe 2 or number 3, right? So when you talk about stigma and medication, yes, it exists in AA, but compared to what? Healthcare professionals are actually the number one source of medication-related stigma in the United States. Very critically, and I'll speak for somebody who has been on medication myself for my recovery, there is nothing anyone can say in AA, in Smart Recovery or NA that would get me to get off my medication, right? Words hurt, but they're words. When a healthcare provider refuses to prescribe buprenorphine to me or methadone to me, which about half people wouldn't prescribe methadone, that is an actual block on medication, right? So these are 2 different axes. Both are terrible, but they're different. So whenever somebody asks you like, oh, there's stigma in NA, it is terrible, but what's the prevalence? And what is it compared to? So to sum up, what I think is happening is this. In the United States, we have a very complicated history and opinions about medication in general. Anyone who lived through COVID, which all of us do, and try to get somebody they love to take a vaccine knows this to be true. It's not just AA or NA that has a problem with medications. My mom has a problem with medications. Everyone in this country has some issue with medications. Doctors have problems, AA, NA. Everyone has some kind of problem with medications, especially when it comes to addiction treatment. No one's doing a good job. That's the problem. All right. Yeah, this is not all that important. One really important misconception that I want to clear up, and my research goes into treatment centers and Alcoholics Anonymous are two different things. Smart recovery and a rehab are two different things. A lot of people will bring AA into a treatment center. A lot of people will bring smart recovery into a treatment center, right? But a treatment center has regulations they need to follow. They're providing a service that people are paying for. That's very different. If you go to an AA meeting, like, oh, I don't think you should be on medication. Well, that they're their own people. If you go to Smart Recovery and somebody says, oh, I don't think you should have medication. Well, Smart Recovery, you don't have to be here, right? But if somebody gets sent to a treatment facility and they bring in these these AA philosophies, these anti-medication philosophies, that's very different. So oftentimes people will conflate the two, right? But they're very separate. And I really, want you to understand this. A treatment center is not the same as AA, even if they're using AA. They have different rules and regulations they have to live by. All right. So I went through the problem, I went through the history, and I am really hoping to figure out a solution. And I probably won't, but that's what I'm trying to do. And you can tell it's a big problem, right? When you look at it from a historical perspective, it's very obvious that medications are useful, and it's very obvious that peer support is useful. And the fact that you get one or the other in most treatment facilities is a crime, in my perspective. Not a literal crime, but a moral crime. And that's what my KO1 proposal is attempting to move the needle on, at least bring awareness to. All right, so this is the current landscape of 14,000 treatment facilities. You see 31% in 2023 or 2024, almost done. 2023 or 2024 on the top right, that's the purple, offer both, right? So you get a medication or medication and a recovery support meeting. About a third have medication only, and about 18% have just mutual help, and 21% have neither, which is terrible. You just get like CBT or group therapy. If you see this slide, the gray is 2020 and the red is 2023. So just look on the very left-hand side, offer both. That's the most important one. So in 2020, only about 10% of treatment facilities, rehabs, offered both medications and recovery support meetings. By 2023, that's 31%, right? So to answer your question, like, what is the crisis of our day is the overdose crisis, right? I believe this is improving. Whether it's improving enough, definitely not, but I do believe it is improving. How do we help it go faster? What's the policy gap? Well, people have recognized this problem, right? So state of California passed the SB 184 law. I'm actually working on a pilot to evaluate this law. It's mandating that all treatment facilities, if you have a license to give addiction services in the state of California, you have to offer medication for opioid disorder, all three. Whether that's happening or not, my pilot is trying to see if it is or not. So the problem is we have these policy mandates, right? We have like Governor Newsom saying you got to offer medications. They don't really say how, right? Which is the hard part, right? If you ever been to like a really old timers 12-step meeting and you're like, yeah, we're gonna make you offer medication, be like, okay, sure, we'll offer medication, right? So like, how do you do that? We don't really know. We just have to do that. That's where we are today. So the patient is often, and especially if you're in a rural or isolated area where you don't really have access to a lot of services, maybe there's one rehab in your entire town or your entire county, that can be really difficult. How would you do that? I don't know. This is something that really doesn't get talked about a lot. Like, I've been in California basically my whole life, and I've lived in San Diego, Los Angeles, and now the Bay Area. And we have to really acknowledge that people who like to go to 12-step programs oftentimes don't live in Los Angeles, San Diego, and the Bay Area, right? They're often lower income patients, they're communities of color, rural patients. They have a religious and spiritual culture already. Maybe they're medical skeptics. And I don't think it's fair to say, like, oh, if you don't like science, we don't care about you, right? That's not how we should be thinking, right? So, in terms of cultural competence, 12-step program specifically may be more culturally congruent to what people's preferred pathways are, especially communities of color, which often get left out in this conversation, right? Oh, we don't believe in medication. It's like, okay, there's a lot of reasons why people don't trust medical institutions. Who prefers the medical model, right? So on the left, higher income people with insurance, predominantly white educated populations, urban patients. So people who live in San Diego, who can afford to live in San Diego, Los Angeles, and the Bay Area, often have advanced degrees and have a lot of education, and they have insurance, and they can go to all sorts of places. There's a hospital there, there's a hospital there, right? Like, oh, I'm going to get medication, right? And that's the divide that we see. You know, like what treatment system are we trying to architect? For whom? It should be for everyone. So we lack knowledge, right? Practically on where does this occur throughout the United States, how clinics successfully or fail to achieve integration, and patient perspectives on what it would look like if integration succeeded. That's where the objective of my KI1 proposal is. Sorry for this thing. So AIM 1 is a national landscape. I showed you a little bit. I'm going to look at all the treatment facilities in the United States. I'm going to create a measure of integration. It's going to be looking at whether you offer medication, mutual help, both or neither. And then AIM 2, I'm basically doing interviews at treatment facilities, looking at factors for integration in a treatment level, looking at administrative burden, looking at organizational structure, looking at leadership, buy-in or not, looking at stigma, all those kind of factors. So looking at why, if you are offering medication, why don't you offer recovery support? If you are offering recovery support, why are you not offering medication? Is it just like hard to do? Which it is. It is hard to do. You need a prescriber, you know all these things. Do you just not know where a good meeting is? Do you not know where to send your patients? It's hard to find a good meeting. We know here. That's why you're here. You need community partners. Maybe you just don't have a community partner and that's it. Maybe you want a community partner, you don't know where to find one. That's an easy problem for us. All right, so here is just a map of looking at, I'm not gonna get into the data here, but if you look at Alaska on the bottom, only 3% of facilities, probably they don't have that many facilities, offer both MOUD, offer both medication and mutual help. If you look at the Northeast there on the East Coast, half of treatment facilities, I think those Connecticut and Maine or something, offer both, right? So you have this huge disconnect between people in Alaska who really have probably just one option or two, and then people on the East Coast in these highly integrated, like Boston, like, oh, you can get all it's like a buffet, right? So we really want to offer all treatments to all people around the country. And it's like, well, why is it so easy to do in Boston and so hard to do in Alaska? That doesn't make any sense. So that's kind of what I'm trying to get at. Against, oh yeah, it's good here. So how am I going to do it? Implementation science has these tools. One of them is called EPHASIS, which tries to quantify the readiness of an organization. So you go into an organization, like if you came to SDSU, we'd be saying, we have all these kind of lists of like, do you know what medications are? Yes or no? Like, what kind of barriers have you faced trying to offer medication? And then flip side, you go in and say, like, do you know what mutual help support is? Yes or no? What are the barriers that you faced? Have you tried it before? So kind of like trying to quantify the barriers within an organization of why it's hard to offer one or the other. And then finally, my last aim is co-designing a solution. So we're going to use something called user-centered design, which is a fancy way of saying focus groups. We're going to use a 4-step process. We're going to understand, which is like journey mapping. You bring people together, you bring community folks, you bring administrators, you bring physicians, and you create a journey map, and then you brainstorm a solution, and then you do kind of a prototype, and then you bring it back, and you iteratively co-design a solution with all stakeholders to figure out what should we do here? So what's the deliverable for patients? We're going to hopefully create decision aids for pathways, script banks for disclosure. So if you're like, oh, I have a medication. I'm going to go to my first A meeting. Like, oh, maybe we should give you like a script in case you have some kind of negative reaction. Like, what should I say? Be like, my doctor says I'm going to stay on this medication. Thank you very much. Something easy like that. Or if you are my sponsor, are you okay with me being on medications? And if they say no, find a new sponsor, right? These simple things like that. We don't know exactly the outcome. And then myth busting, right? That's easy. For providers, warm handoff protocols. A lot of physicians are really just like, don't know. Like they really want to help their patients. They don't really know what to do. So we'll have a protocol, be like, okay, you want to connect somebody to a meeting. Here's a peer support service. They're going to come. They're going to get your patient. They're going to walk them to their first meeting. They're going to stay with them maybe, right? So having these warm handoff protocols, peer navigator scripts. For organizations, we'll have blueprints and checklists. So your organization offers medication and you want to start implementing peer support or recovery support. These are the things you probably need to do, right? So kind of give yourself a report card on like how good you are at these things. And like once it gets to a certain level, your organization will probably do pretty good. So that's kind of like the outcome. So the main innovation for my proposal is reframing the either or into a both and. The current state, we have the medical community and we have the community. Maybe not even on purpose, but providing the patient with this forced choice. It's the my way or the highway. I don't even think it's that like sinister. It's just how the treatment system is today. And, I think if we want to make real progress on, the tragedy of our current crisis, we're going to need to use all our best tools. And the fact that we don't, I think is a real not so good thing and something that we can work on. And I hope that I can come back and share with you what I do and find out. And this is the motto. Where others see irreconcilable philosophical tensions, this research hypothesizes modifiable implementation challenges. Thank you very much.
Hello. So I just was wondering, based on your research, how co-occurring disorders factors into a lot of this.
So my research to this point is really looking at the family and the system, and our inclusion criteria was really alcohol or other drugs and not necessarily other addictive behaviors. So I don't really have anything to add to what we have found around co-occurring, but it's just something that we need to explore further, I would say. And I feel like we're a bit behind on that. So
I'll echo that. I think we're far behind on that topic. My research specifically doesn't look at co-occurring, but it is deeply ingrained in everything we do. So I would think that's definitely a future priority and current priority that we need to spend more time with.
So I'll also mention like process addiction co-occurring. So for gambling and betting, we know that is a risk factor for other addictions. And so as we move into different spheres, I think we might get better at understanding that and working with it. But it's a challenge. And some of it could be around that stigma issue when you're trying to address one, and it may not be considered as serious by those who are having a different. So I think we're going to start seeing some of that on a college campus as we start addressing process addictions, because we do have to address process addiction, especially the gambling and betting. It's really coming up pretty hard.
A follow-up, your recovery program is open to, I know ours at Mississippi State is open to any issue, addictive behavior process and so forth. Is that how y'all's is set up here too?
Well, we're set up for it, but we're not experiencing it. It's hard to get people into the door. So I can't say that we've tackled that yet.
Hey, how y'all doing? My name is Isaiah. I just wanted to say thank y'all for all of this. And this is my first time at SDSU. This colloquium is beautiful and appreciate all y'all research. Can I rephrase this question? Well, the through line between the research that I saw was financials, and basically too, after hearing Dr. Lang's encounter in DC dealing with the financial, the federal connecting there. In my experience in living in California in particular, a component of this that I was thinking about was sober livings in homes and how it's all connected through everything that y'all said. And as far as being here, what I also heard is like how we can keep the message going, how we can, what's that next level of things that we can do. So when I think about sober livings in homes as they're connected to 12-step, any type of mutual support, how do you see that connecting to the collegiate level and just across the board nationally? Because what I also know about California since I moved here is that sober living, when I think about not so much prevention, but recovery is a huge financial business.
If you're speaking specifically about the college campus, I think there are some opportunities for sober living that do exist across the nation in CRPs. It varies. So some do offer that, some offer some version of that, some offer residences that are specifically focused only. Some offer opportunities where there's just a mixed bag of just different folks, So I think as far as incorporating that piece, when you think of it like a puzzle, we've got lots of moving pieces. I definitely think that is something that is utilized in collegiate recovery. It just varies from institution to institution, similar how family programming does. There's lots of pieces that are there, and some may utilize more than others. And sober living is definitely one of those examples.
Sort of adjacent to that concept, a lot of campuses, and SDSU has it as well, may have a hall that is substance-free. But I don't think many of those across the nation actually are sort of integrated into the recovery space, because it doesn't necessarily mean they're in recovery. It could be their parents checked a box saying, I want my kid in a without it. So it's not clear that the motivation is even around that. But it is an important component that it exists at least. But that's where a lot of campuses are in that regard.
Thank you for your question, and thank you for your engagement and participation, and welcome to SDSU. Sober living can also be called recovery housing, and I would say recovery housing, sober living is a huge priority going into the next X amount of years. Where I am in San Francisco and the Bay Area, there has been a big paradigm shift away from housing first. Housing first is a philosophy of providing a house first, regardless of, so basically no strings attached. And there's a new mayor, Mayor Lurie, and also nationally, there's a push now to incorporate recovery housing and sober livings into that treatment pathway. So it's moving away from providing shelter and housing with no strings attached and more into a little bit of a coerced pathway into sober livings, recovery housings with other carrots and sticks, right? So recently there was legislation at the federal level, the Support Act, which gave money for recovery housing research. Recently, RFK and President Trump had a $100 million Great American Recovery Initiative where recovery housing was one of the main components. So to answer your question, it seems like recovery and recovery housing and sober livings will be a priority nationally and at the state level. Whether it's effective or not, we don't really know. The problem is it's just like a loose network of profit-driven people, and kind of cleaning up that industry is going to be hard, and that's what we're trying to do. There are efforts made to standardize and certify with NAR, NARR, and they're trying to create certification. So it's not just like you're a sober living, you're a certified sober living, right? So they're trying to do that. But this kind of stuff takes a long time. So I think you're right. That's the direction we're going, but it's unclear how we're going to get there. Especially like if you just keep cutting funding and grants, I don't see how we can do it. But we're trying. I think that's where we're trying to go. So thank you for your question.
Some questions from the chat.
Okay, this is from William Online. Treatment centers offering access to MHGs makes attendance to MHGs compulsory in many cases. What are the dangers of that?
Yeah, licensed treatment facilities that force people to go to mutual help groups. I'm not sure how widespread that is. I'm sure it does happen. You talk about dangers. That's a really good question. I think exposure in a controlled setting is probably maybe ideal. If you're within a treatment center and they're exposing you to a pathway, and if something bad were to happen, you are under the care of licensed professionals, right? So I guess in that setting of negative experiences, you would want to go back to a setting where it's good. Likely you're being taken to a meeting or a environment where the treatment center has a relationship. So that's a positive, right? So likely you're not being sent to a random place where you're going to be exposed to maybe a quote unquote bad meeting, but that's also may or may not be true. I think the question more so is how do we create structure so that treatment facilities know what to get their patients into and what dangers to protect them from. And that's where the research comes into, providing scripts and other materials. The specific question though, like what are the dangers? It's hard to say. Optimally, if you want to expose a patient to a new environment and you go with everyone else that you know and also with licensed professionals, and you come back to a place with licensed professionals, that might be ideal. But yeah, I haven't really thought too much about that. So that's what I have to say.
I'd say on the collegiate recovery programming level, our programs are always voluntary to be involved with. They have not been tied to any type of penalty. As far as I have ever known, it is an opportunity for someone to voluntarily walk through the doors and participate, and they can voluntarily walk out of those doors. So I think on the collegiate recovery programming, we are not treatment again, but it is very much a voluntary opportunity to be involved, to access support, and to continue your recovery using CRPs as another resource in your lifelong journey kind of thing.
Do you have another question from the?
Yeah, another question from online. Is treatment completion an effective outcome measure for recovery success? And a second part to that question, what are outcome measures that we can use in today's funding climate that'll shape treatment to be more effective?
Could you repeat?
Sure. Is treatment completion an effective outcome measure for recovery success? It's the first part of the question.
Well, I'll reiterate it. I can't answer it. I'm hoping you can. What's your dependent measure? Yeah, so why don't you talk about that?
Yeah, I think we have to differentiate between remission and recovery there. I think if you talk about remission, so if you have a substance use disorder and you complete treatment, you're much more likely to remit from substance use disorder. So I don't think that's really debated. I think maybe your question is like, yeah, it's kind of confusing. So then recovery is very different than remission, right? So treatment, yeah, that's all I got. I'm sorry. Would you take a step?
Yeah, I was just wondering, I wish I had a little bit more information on the question so that I felt like I was getting at what they were looking for. It kind of sounded like if you complete a program, is that helpful? I would say yes, but just because you complete doesn't mean that it sticks. So I don't have an answer to, I don't think.
Yeah, based on my interpretation of this question that came online, and if whoever submitted that would like to respond and clarify, that'd be great. But it does seem like they're asking, can you map treatment completion, like whatever the path of that is according to the facility or center, how well does that correlate with actual recovery success, which I think we talked about a little bit earlier. And so they're trying to get to the heart of the issue of, if that isn't a good metric for recovery success, what can we map to that? I think that's what they're going for.
Okay, I can take another stab at it then. All right. So the best thinking that we have is that recovery is a process. It's not a one-time thing. And we know that here, especially in the young adult population and the collegiate recovery population, there are histories of trajectories of substance use and substance use careers, you can call it. So to answer your question, one treatment attempt is often insufficient to, I guess, what you would call it, achieve long-term recovery. It's more of like a career or a trajectory. The best available evidence we have is 4 serious recovery attempts. So you can call that treatment attempts to achieve, a level of sustainability or sustainability. So yeah, we're moving away from single treatment episodes, like completion of treatment of one time, and more into these trajectories or pathways. And I think that maps perfectly into collegiate recovery. Like a lot of students 18, 19, 20 years old may not have like full-blown substance use disorder. They may start substance use disorder, and then as they get into their careers or into their family life, they go into treatment the second or third time, right? So it's about shortening these trajectories, introducing people into treatment language, treatment modalities, behavioral modifications early to shrink these trajectories and reduce overall damage. So to answer your question, one treatment attempt and completion, I don't think is sufficient anymore. It's more about serious recovery attempts, we call it. So about 4, on average, 3 to 4 serious recovery attempts. And that could be across your whole lifetime. I hope that answers your question.
Yeah, so that was the first part of this 2-part question. If anyone in the room has something we can add in too, but just to tie back in the second part of the question, in terms of the funding environment, we mentioned grants coming and going. What are the best metrics that we could present to the powers that be to sort of try and secure that funding that doesn't feel, very solid at the moment? In terms of, everybody wants to see numbers or a spreadsheet or something. I know this is very difficult to quantify, but that's sort of what we're asking is how do we, put it into that format for someone to understand, the gravity of it and invest in it continually.
I would say our best evidence-based practice at the time is what we can present scientifically. I think we have to be careful about just coming up with things, policies, funding mechanisms for which we don't utilize an evidence-based approach. I think that how we can contribute towards the effort is continuing to get better evidence-based practices, either confirming or updating our standard practice.
I think we really need to show outcomes. A lot of money. Like number one thing, treatment is very expensive. Treatment is very expensive. So in San Francisco, there's a nonprofit called St. Anthony's, and they do comprehensive treatment. Talk to the CEO, and he's like, "Yeah, for one person, it's about $100,000 a year, right? It's a lot of money." And we know that, like for example, when you hear prison is expensive, we all kind of like, "Yeah, like prison expensive. Like we shouldn't be putting it in prison, right?" Treatment is very expensive, right? And it's not that we haven't tried treatment. California especially has spent a lot of money on treatment, and there's a huge profit industry that has sprung up because of this. So you know, if you're paying for treatment and you can't really show that it's working well, the buyer kind of has a right to be like, well, I don't want to buy this product anymore. So we need to be a little bit better as a industry of like really tracking like what we're doing, evidence-based programs, and showing the taxpayer and really the country that treatment the money is being used effectively. And I don't think we're doing that currently.
Thank you. Alrighty, unless we have any other questions here in person. Yes.
Obviously, AI is taking over a lot of things. How do you think that plays into recovery or future directions and where that might go?
I'm bullish on AI. I think that's great. I think answering your question about or piggyback off my previous answer of treatment is very expensive. There are people who will never enter treatment for whatever reason, cultural reasons, shame, guilt, whatever. So two sides of that. For people who never want to seek formal treatment, AI products, maybe not now, but in the future, can be helpful in that respect. And then also within the treatment center, if we can reduce a lot of the administrative barriers, the billing, the scheduling, within a treatment center, there's like the bed that the person sleeps in, and then there's so many other services around that are expensive. It's like scheduling the person to get their Medi-Cal, they have to get taken to the office and dentist, and there's peer support, and like there's a huge team that wraps around this person, and it's very expensive, right? So like lowering the cost of treatment so that the person, like more of the money goes towards the bed and the person, and removing like the administrative costs. If it can do that, I think it would be very helpful. But that's, maybe in a few years.
AI is a tool. It can be used as a tool when used appropriately. I think coming from the academic side, I think it's a constant struggle for us as far as helping people think for themselves and learn how to write and talk versus using AI as a substitute. So I think that it's definitely a tool. I think we can be innovative. We can utilize it, incorporate it. I think it's bright. Our future is bright with how it could be used. However it might be used in the future. I think it's a tool, though. You have to acknowledge it on the basis of what it is.
Yes, thank you. My question is really wanting your opinion when you talk about for-profit treatment centers, AI, other treatment centers. If we exclude profit treatment centers, isn't that not a good thing? I mean, I know we'd rather not have, profit treatment centers, but don't we want all the resources available that we have, or am I wrong?
Yeah, I never meant to suggest that we should get rid of for-profit. That's not what I said at all. I think the reason that we are in this mess is because for a long time, for generations, really, the U.S. healthcare system and the federal government, and really state governments, did not want to enter into this space. It was an ugly space. So peers and people in recovery created this industry really out of the goodness of their hearts. And then it became a lucrative industry, right? So it kind of sprang up as a grassroots organization. And now it's taking this turn where, they're literal millionaires who are 20 years old because they created a sober living and now they have 20 sober livings and they're 22. It's really a artifact of like it being the wild, wild west. I'm not saying we should get rid of them. I'm saying it's time to take them seriously. And, if you go to a Chipotle, they get all sorts of licenses. You got, bartending licenses. You got to go through all sorts of like checks and balances, right? So it's time to do that for the sober living environments. It's time to do that for the treatment facilities. They have to have licensing. People need to inspect. If people get hurt in there, there needs to be accountability. It's time for those kind of measures. I'm not saying to get rid of them. It's time to mature into a real industry. Accountability.
Alrighty, well, that wraps up the conference for today. Thank you so much for your expertise and your commitment to recovery science. We really appreciate it. And thank you everyone for joining us this year. I really hope to see you all next year. And if you have any questions for us, we'll stick around for about 20 to 30 minutes. But again, thank you so much for coming to our annual Recovery Science Colloquium.
We have a question for this.